My dear students, in this video, I am going to discuss about ICU acquired weakness, which is a real problem in the ICU, and the various phenotypes associated with this ICU acquired weakness. Let us start with this case. A 60-year-old male of type 2 diabetes and hypertensive is admitted with septic shock from pneumonia. He requires norepinephrine, intubation, and mechanical ventilation. And over the course of his stay, he receives deep sedation with midas and fentanyl for 10 days, intermittent neuromuscular blockade with vecuronium in the first 72 hours, methylprednisolone 60 milligrams per day for ARDS, again for 7 days. And he also receives insulin for tide, but not truly hypoglycemic glucose control. By day 10, the vasopressors are off, ARDS has improved, but every spontaneous breathing trial fails because of low VT and rapid shallow breathing. On day 12, he is awake, he follows commands and complains of profound limb weakness. On examination, he is conscious, oriented, has intact cranial nerves. He is flaccid quadriparesis on his muscles with approximately 2 by 5 and or the proximal and 3 by 5 on the distal muscles in all limbs. Reflexes are globally reduced with difficult to elicit at ankles. The distal pinprick and vibration is slightly reduced in feet compared with upper limbs and also limited by cooperation. There are no fasciculations, no myotonia. The labs reveal CPK of mildly elevated 350 international units, normal electrolytes, normal thyroid function, along with adequate nutrition. Now, the diagnosis is made of ICU acquired muscle weakness. Now, what are the different phenotypes of ICU acquired weakness and how to diagnose it? And also, to which particular characteristics of ICU acquired weakness does this case follow? If we go by the basic definitions, we find that there are three phenotypes of ICU acquired weakness. The first phenotype is critically illness polyneuropathy, which is diffuse, symmetrical, primarily distal. Axonal sensory motor polyneuropathy occurs in the context of critical illness, particularly or typically sepsis with multi-organ failure, which affects the limbs and the respiratory motor axons and the distal sensory fibers. The second phenotype is critical illness myopathy, which is diffuse, symmetrical, mainly proximal primary myopathy, often myosin loss with thick filament myopathy, and this also affects the limbs and the respiratory muscles in critically ill patients. And the third phenotype is critical illness polyneuromyopathy, which is an overlap syndrome in which both primary axonal neuropathy and primary myopathy coexist, clinically presenting as ICU acquired weakness with mixed neurogenic and myopathic electrophysiological and sometimes biopsy features. So critically illness polyneuropathy is primarily axonal sensory motor neuropathy. Critically illness myopathy is primary myopathy, and critically illness polyneuromyopathy is the overlapping polyneuromyopathy with combined features. Now, the important risk factors for these include severe sepsis or septic shock with SIRS and ARDS, prolonged mechanical ventilation and immobilization, especially failure to wean, multi-organ failure, particularly MODS with prolonged ICU stay, high dose or prolonged corticosteroid therapy, and non-depolarizing muscle blockers like vecuronium, pancuronium, atracurium, etc. Metabolic derangements like hyperglycemia, hypoalbuminemia, electrolyte abnormalities, systemic hyperpyrexia, older age, and female sex, they have been reported as additional risk factors in some series. When we see the clinical features, the critical illness myopathy usually manifests after several days of critical illness with diffuse symmetric limb weakness, typically which is more proximal than distal. There is flaccidity of the tone with reduced or normal reflexes. Cranial muscles are often relatively spared. Respiratory muscle weakness leading to failure to wean from mechanical ventilation despite resolution of lung mechanics or gas exchange problems is a common feature which is seen in most of the patients. Sensory examination is usually normal, which helps it to distinguish critical illness myopathy from critical illness polyneuropathy. If sensory loss is present, then there is concomitant presence of critical illness polyneuropathy is likely. So in awake cooperative patients, the MRC sum score is less than 48 out of 60. And whenever it is present, it suggests ICU acquired weakness, either critical illness myopathy or critical illness polyneuropathy or polyneuromyopathy. So for diagnostic evaluation, one, there is the clinical features like generalized flaccid weakness with preserved sensation occurring in a patient with recent or ongoing critical illness with no alternative explanation like stroke, GVS, or myasthenia. Nerve conduction studies in pure critical illness myopathy, sensory nerve action potentials are preserved and the motor nerve conduction velocities are relatively normal with reduced compound muscle action potential amplitudes due to muscle involvement. The needle EMG shows short duration, low amplitude motor unit potentials with early recruitment and spontaneous activity, again, which is consistent with myopathy. So these are in the form of fibrillations with positive sharp waves. Indirect muscle stimulation helps distinguish myopathy from neuropathy when standard nerve conduction study and EMG are equivocal. Muscle biopsy shows loss of myosin filaments, type 2 fiber atrophy, and sometimes necrosis or vacuolization in myopathy. Myosin loss myopathy generally carries a better prognosis than necrotizing forms. Laboratory tests, the CK may be abnormal or only mildly elevated. If there is marked CK rise early in the course, it is not obligatory and its absence does not exclude critical illness myopathy. So the diagnosis essentially combines clinical assessment, electrophysiology studies, and sometimes even muscle biopsy. So let us look into this diagram. It gives a very simplistic and practical understanding of two-tier muscle strength assessment where MRC sum score, that is MRC SS, it is divided. This should be assessed as soon as the patient awakens and at the ICU discharge. So these are the two phases, and one is the hand grip dynamometry, which we normally do. This can be done at the bedside. It can be used during the ICU stay as a quick screening tool. So if the hand grip dynamometry is absent, then the patient can be subjected to other tests. And if it is present, then one can avoid tests. So both at ICU admission, when the patient is cooperative ITU discharge, or in persistent weakness, this can be tested. So if the presence of hand grip test indicates of more than 11 kg males and more than 7 kg in females, implies that there is actually no ICU acquired weakness. So while performing the hand grip dynamometry, it is important that no anti-gravity strength in the elbow and or the wrist, they should be excluded. So if we have impression of muscle weakness and we know that the critical illness precedes muscle weakness, then we have to go for clinical assessment and which should be valid and reliable. If the hand grip test is reduced, we do a MRC sum score and check whether the MRC sum score is, if it is less than 48, we go for rehabilitation for a duration of 1 to 2 weeks and the condition should improve. Otherwise, we have to perform simplified electrophysiological tests, and if they cannot be performed, we can go for muscle deconditioning. So if the electrophysiological tests are abnormal, then we go for NCS, EMG, or NM transmission, and thereby we can diagnose either critical illness myopathy and critical illness polyneuropathy. So we consider EMG muscle biopsy if we are not able to diagnose, if the differential diagnosis between critical illness polyneuropathy and myopathy is not established at this stage, then we consider EMG muscle biopsy, we consider increased compound muscle action potential duration or direct muscle stimulation in non-cooperative patient to reach to our diagnosis. So this is roughly a schematic flow of when to consider which form of examination and how to exclude the ICU acquired weakness one by one and come to know at the particular phenotype. So differentiating critical illness myopathy, here the proximal weakness is greater than the distal weakness. There is preserved sensation, predominant myopathic changes on the EMG, and preserved sensory potentials on the nerve conduction studies. In critical illness polyneuropathy, here the distal weakness is greater than the proximal weakness with distal sensory loss. There is reduced sensory and motor amplitudes on nerve conduction studies, which is consistent with axonal neuropathy. And in critically illness polyneuro uh, myopathy, there is combination of proximal weakness and distal sensory loss with mixed neurogenic and myopathic features, which are visible electrophysiologically. So clinically, critical illness myopathy, critical illness polyneuropathy, critical illness polyneuromyopathy share limb and respiratory muscle weaknesses, but they differ in distribution and sensory findings. So this is again the table which shows the differences in the three entities on the basis of primary site of lesion. Primary site of lesion is axonal motor and sensory nerves in polyneuropathy, skeletal muscle fibers in myopathy, and both nerves and muscles in polyneuromyopathy. The weakness pattern I have already mentioned that it is distal more than proximal in cases of polyneuropathy, proximal more than distal in cases of myopathy, and generalized proximal plus distal in polyneuromyopathy. Sensory findings, sensation is usually normal in myopathy, and distal sensory loss is common in polyneuropathy. Reflexes are markedly reduced and typically are or absent. The other than that, the compound muscle action potential is of low amplitude, and the nerve conduction study can be normal in critical illness myopathy. And the biopsy shows axonal degeneration and denervation atrophy in critical illness polyneuropathy, and in myopathy it shows myosin loss and fiber atrophy, whereas in polyneuromyopathy there is a combination of the two types. The recovery trend, it is important to understand, recovery is often faster and better in critical illness myopathy if it is particularly myosin loss variant, and it is often slower and incomplete in polyneuropathy, and it is intermediate or even slower in patients with polyneuromyopathy. So these are the various features in terms of these three phenotypes which one needs to understand, and the course of the illness needs to be interpreted in terms of these findings. If you want to know the management, the aggressive treatment of sepsis and organ dysfunction is primary to minimize inflammation and MODS. Avoidance or minimization of the risk factors like limiting duration and dose of corticosteroids and muscle relaxants when possible, optimizing glycemic control, correcting electrolyte and nutritional derangements are all very important. Early mobilization and physiotherapy, including passive and active limb exercises, and early sitting or standing or ambulation as feasible to counteract the immobilization related muscle loss. Respiratory physiotherapy and weaning protocols with tracheostomy when appropriate to facilitate liberation or weaning from mechanical ventilation. And of course, multidisciplinary rehabilitation after ICU discharge, integrating physical, occupational, and when needed, speech therapy too. So from this, it is very clear that there is no specific pharmacology therapy, but the management is largely preventive and also supportive. Regarding the course and prognosis, the critical illness myopathy tends to have an earlier onset and a faster recovery than pure critical illness polyneuropathy, particularly in myosin loss forms. Many patients show substantial motor recovery over weeks to months, but ICU-acquired weakness can persist and contribute to long-term disability and impaired quality of life. And severe critical illness myopathy is associated with prolonged ventilation, longer ICU and hospital stays, higher healthcare costs, increased mortality. But it should be remembered that it is often a marker of illness severity than a direct cause of death. Now, if we see and go back to our patient and try to find out why our case fits as a critical illness polyneuromyopathy and not as a pure critical illness polyneuropathy or critical illness myopathy, because here the risk factors present for both neuropathies and myopathies like sepsis, multi-organ failure, steroids, NMBS, prolonged ventilation, and immobilization. Clinically, there is generalized weakness, somewhat more proximal, but with distal sensory loss. So there are features of both myopathy and polyneuropathy, and areflexia, which suggests combined neuropathic and myopathic process. In the NCS, there is reduced compound muscle action potential plus reduced snaps. So there is axonal sensory motor neuropathy component is there. And EMG shows both myopathic, which is characterized by short duration and low amplitude maps with early recruitment and neurogenic features. So the muscle action potential is also the important aspect which was seen here. And the direct muscle stimulation is abnormal, indicating muscle membrane inexcitability, which is consistent with the myopathic component or the CIM. So at bedside, we will label this as ICU-acquired weakness due to CIPM, which explains the difficult weaning and predicts relatively low but possible recovery if organ failure continues to resolve. So at the end, but the take-home message would be that ICU-acquired weakness is common in sick, ventilated patients, and it strongly predicts prolonged weaning and poor functional outcomes. The main phenotypes are axonal sensory neuropathy, that is critical illness polyneuropathy, critical illness myopathy or primary myopathy, and mixed critical illness polyneuromyopathy. So we will have to think about distal sensory loss plus low snaps as critical illness polyneuropathy, preserved sensation plus normal snaps with low compound muscle action potentials as critical illness myopathy, and all share similar risk factors like sepsis, MOD, steroids, muscle relaxants in immobilization, and also early sepsis control, minimum offending drugs, early immobilization, good nutrition, and glycemic control are no doubt unequivocal in preventing them. So, thank you.